Hey everyone, uh, my name is Dr. Akanksha Thakkar. I would like to share my knowledge on the topic of tooth development, eruption, and anatomy. I would like to start my presentation with quoting some beautiful inspirational quote. A journey of 1,000 miles begin with a single step. So we all are going to take that step today. In this, I will cover introduction, stages of tooth development, phase of eruption, anatomy of primary teeth, anatomy of permanent teeth, conclusion, and in last, I will show you the references. We will start with the introduction. Why it is important to know about all these things like development, eruption, and anatomy of the tooth. First, to monitor the developmental milestones in the developing child, to correlate dental age with the skeletal age, and third is to anticipate the developing malocclusion, to check for dental anomalies in syndromic and non-syndromic patients, age estimation. All this can be helpful points if you know about the basic concept of development of tooth, eruption, and anatomy of teeth. First, I will describe some basic terminology that we are going to see in our presentation. First, enamel organ. What do you mean by enamel organ? Growth of dental lamina. Uh, it is known as enamel organ. The dental lamina, tan in maxilla, and chin in mandible, arranged in the form of horseshoe shaped. And then dental papilla. What do you mean by dental papilla? It is ectomesenchymal condensation below the enamel organ. Then dental sac or dental follicle. It means ectomesenchyme surrounding enamel organ and dental papilla. The development of tooth begins at the sixth week of intrauterine life, followed by the formation of primary epithelial band. In the seventh week of intrauterine life, primary epithelial band divides into the two parts. First is the dental lamina, and second is the vestibular lamina. Uh, in the dental lamina is responsible for the all deciduous teeth, and also it further divide into two extension. First is a lingual one, and second is a distal extension. In lingual extension is responsible for the all succedaneous permanent teeth, whereas distal extension is responsible for the permanent molars development, who doesn't have any succedaneous teeth. Vestibular lamina responsible to for the development of oral vestibule. Basically, stages of tooth development can be divided based on the morphology and physiology. Based on the morphology, defined into the five stages. First is the formation of dental lamina, then bud and cap stage, early bell stage, advanced bell stage, formation of enamel and dentinal matrix. It is correspond to the physiological stages like formation of dental lamina is correspond with the initiation. Bud and cape stage is a corresponded with the proliferation. Early bell stage is correspond with the histodifferentiation, and same as that, advanced bill stage is the correspond with the morphodifferentiation and formation of enamel and dentate matrix, also known as apposition. Initiation. In initiation, we first see fate of the dental lamina, which is the responsible for the development of the tooth. As the teeth continue to develop, they lose their connection with the dental lamina, then later break up by mesenchymal invasion, which is the first incomplete and does not perforate the total thickness of the lamina. Then fragmentation of the dental lamina progress towards the developing enamel organ. Any particular portion of the dental lamina function for much briefer period since only a relatively short time elapsed after initiation of tooth. Once tooth initiation will start, dental lamina has a minimal function or contribution for that. After initiation of tooth development, before the dental lamina begins to degenerate. After initiation of tooth development, before tooth development starts, the dental lamina begins to degenerate because its role is fulfilled now. However, the dental lamina may still be active in third molar region because its uh, development starts late after it has disappeared elsewhere except for the occasional epithelial remnants we can see sometime. Vestibular lamina, labial and buccal to the dental lamina in each dental arch, another epithelial thickening develops independently. It's known as vestibular lamina and also termed as a lip furrow band. Okay, we can clearly see here lining of vestibular lamina marked as a VL in this picture. Subsequently, hollow and form the oral vestibular between the alveolar process of the jaw and the lips and cheek. What it will form, uh, the oral vestibule between what structure alveolar portion of the jaw, lips, and cheek. Uh, Now, why it is important to know about all this? If any defect occur in this stage of the tooth development, it can result into the three anodontia, supernumerary teeth, or ectopic initiation. Anodontia means this. It means absence of the teeth. It can be partial or generalized. Rare genetic disorder characterized by the congenital absence of the all primary or permanent teeth. What can be caused for the anodontia? The mutation of the PAX9, MXX1, and AXIN2 gene. Another defect is a supernumerary teeth. If it divides multiple time, then it needs to be, then it results from the extra tooth in the oral cavity uh, other than 20 primary and 32 permanent teeth, that known as supernumerary teeth. Ectopic initiation, it initiate the tooth-like structure formation in another part of body. Example of that can be dermoid cyst, as we can see in this picture. Proliferation. In proliferation, we are going to see two stages, birth stage and cap stage. First, we will start with the birth stage. Enamel organ resemble a small bird-like uh, projection, like we can appreciate in a picture I have shown in the PPT. Peripherally located low columnar cell and centrally located polygonal cell we can appreciate in the histological picture that is present here. The surrounding mesenchymal cell proliferates and result into condensation of cell in two areas. First is the dental papilla and second is the dental sac. Then we will start the cap stage. Unequal growth in the different part of the tooth would resemble like cap. Shallow invagination on the deep surface of the bird. Peripheral cell cuboidal cover the convexity of the cap outer enamel epithelium, and cell in the convexity of cap out of the cap is the columnar cell inner enamel, also known as the inner enamel epithelium. Polygonal cell begins to separate due to water being drawn into the enamel organ from the surrounding dental papilla and result into star-shaped stellate reticulum that we can appreciate in the center. In the cell, the center of the enamel organ are densely packed and form enamel signaling center and vertical extension of the enamel knot, enamel cord, and reservoir of the dividing cell. Applied aspect of this stage is if any abnormality occur at this stage can result into the microdontia or macrodontia. Microdontia means the smaller size of the tooth as compared to the normal. Um, Either it can be true generalized microdontia, relative, or focal or localized. Generalized means all the teeth in the dentition are smaller than normal. Relative means the one of the teeth or adjacent teeth are larger um, than the teeth. So it seems like it's relatively small than adjacent teeth. Focal or localized, like for a best example for that is the peg laterals. Macrodontia, teeth are physically larger than the usual. Like we can appreciate in the last picture, central incisor are the bigger here as compared to all the other teeth. Now proceed with the histodifferentiation and morpho differentiation, like early and late bell stage. First, we will see histodifferentiation, which means early bell stage. Due to continued uneven growth of enamel organ, it acquires bell shape. Shape of the crown is decided. Now, inner enamel epithelium have tall columnar cell, which known as ameloblast, now which results in the enamel formation. This cell attached to the one another by junctional complex laterally and to cell in stratum intermediate by desmosome. A strong influence of underlying mesenchymal cells of dental papilla, which later differentiate into the odontoblast. Stratum intermedium, a few layer of squamous cell between inner enamel epithelium and reticulum, closely attached by the desmosome and gap junction, essential for the enamel formation. Do ciliate reticulum expand further due to continued accumulation of intracellular fluid. As the enamel formation starts, the ciliate reticulum collapses to a narrow zone, thereby reducing the distance between the outer and inner enamel epithelium. Outer enamel epithelium is formed by the low cuboidal cells. These cuboidal cells later assume a columnar form and produce the dentin thrown into folds which are rich in capillary network and provide source for the nutrition for the enamel organ. Before inner enamel epithelium begins to produce enamel, peripheral cells of dental papilla differentiate into the odontoblast, which are going to secrete are responsible for the formation of dentinal tubules in future. Dental lamina extend lingually for their subsequential dental lamina as it gives rise to enamel organ of permanent teeth. Dental sac, circular arrangement of the fibers resemble a capsule. Around the enamel organ, the periodontal ligament fibers that span between the root and the bone. Now proceed to the advanced bell stage. I hope you are with me. I know it is very dry topic and things are too much to be remembered, but I have tried to make it easy for you guys. I hope it will help you to grasp everything. In this stage, mineralization and root formation will begin. The junction between the inner enamel epithelium and odontoblast outlines the future DEJ. Dento-enamel junction will form. Formation of dentin occur first along the future DEJ in region of future cusp and proceed pulpally and apically. After the first layer of dentin is formed, the ameloblasts start lay down enamel over the dentin in the future of incisal and cuspal area. Once the first layer of dentin, which is known as predentin, has formed, then enamel formation will start in the direction of incisal or cuspal area, whereas dentin formation will proceed in pulpally and apically. The cervical portion of the enamel organ give rise to Hertwig epithelial root sheath, which is the outline of root, thus responsible for the size, shape, and length and number of the roots. Root formation begin after enamel and dentin formation has reached the future CEJ. What do you mean by CEJ? Cemento-enamel junction. Hertwig enamel root sheath remnants, also known as rest of molasses, which we will be seeing later in during your PDS. It's important and everything. If any defect occur at this stage can result in the gemination or fusion. What do you mean by gemination? The partial or complete cleavage of single tooth gum. Like single tooth gum is partially or completely divided into the another tooth gum. If it is a partial differentiation, then it will resemble like two crowns but single tooth. But if it is completely divided, then it will result in the two same appearing crown along with the root. It also known as tweening. Then we will come to the fusion, either complete or incomplete union. It is opposite to the gemination. It will unite two adjacent to germ and which normally are separated to germ, right? How we are going to differentiate between the gemination and fusion by counting the teeth present in the dentition. If teeth present in dentition are more than normal, that means tooth which we can see has uh, witnessed gemination, but tooth number is less, then it means it is fusion, that two tooth germ has been combined. This in this picture we can more clearly differentiate between the fusion, gemination, twinning, and concussion. Concussion means the fusion of the two tooth root by only cementum. No fusion between dentin or any other part of the tooth. Just cementum will be fused between tooth, known as concussion. Now we will proceed to the opposition. Opposition means growth of enamel and dentin layer like deposition of an extracellular matrix. This type of growth is additive and signifies fulfillment of the plant's outline at the stage of histodifferentiation and morphodifferentiation. Oppositional growth is characterized by regular and rhythmic deposition of extracellular matrix, which it is by itself incapable of future growth. Periods of activity and rest alternate at definitive interval during tooth formation. Apply aspect of the opposition stage is either it can result into the dense invaginatus, amylogenesis imperfecta, dentinogenesis imperfecta, regional odontoplasia, dentin, dentin dysplasia can also occur if any defect occur at the stage. First, we will start with the dense invaginatus, or also known as dense intent. It means malformation of tooth, probably resulting from an infolding of the dental papilla before the calcification. The den invaginatus is classified by the Ohlers in three types. Type 1, confined to the crown. Type 2, extend past the CEG but does not involve the periapical tissue. And type 3 also include the periapical tissue. We can clearly see in this picture like tooth-like structure within the tooth. In coronal portion, you can appreciate it. Then we will see what do you mean by dense invaginatus. It is like cusp-like elevation of the enamel located in the central groove or lingual ridge of the buccal cusp of premolar or molar teeth. Like it will be like extra cusp in the occlusal surface of the teeth. In simple term, we can see a difference between dense invaginatus and evaginatus in this picture. Dense invaginatus, like it will in dental papilla will enfold inside the crown and leads to lingual pit extension. And then in case of dental evaginatus, so there will be outside extension resulting in the accessory cusp and pulpal extension. Another artifact can be enamel pearl. The formation of ectopic enamel requires the presence of differentiated amyloblast apical to the CEG. In human, Herdwick epithelial root sheet or its residues, the which known as rest of molasses, have been implicated as this likely source of ectopic enameloblast. It will result into the cusp-like projection in the lingual surface. It is the extra nodule of enamel on the root surface you can see. Basically, there's no need for the treatment here, but it can be difficult. It can cause difficulty during the extraction of the tooth or during the grip or orthodontic tooth movement can be difficult in such tooth. Then followed with the talon cusp as a result of outward folding of the inner enamel epithelium and transition of the cells of mesenchymal papilla, like this like cusp-like structure on the lingual surface of the anterior teeth. It's more similar with the dense evaginitis. Just only difference is that there is a elevation of enamel, and here it is the outer folding of the inner enamel epithelial cell. In this, it will also have enamel, dentin, and pulp inside it. Then, fifth is taurodontism, like failure of Hertwig's epithelial sheet diaphragm to invegetate at the proper horizontal level. Like normals, we can divide it into four types. Normal cynodent, mild hypotaurodont. Like its furcal area is more below compared to the normal teeth. In moderate, almost at the middle third. We can appreciate the furcal area going down as compared to the normal teeth. And in severe taurodont, it will almost at the apical one third. Enamel hypoplasia occur in the form of pits, grooves, or larger area of missing enamel in the normal teeth. Amelogenesis imperfecta, developmental disorder, alteration in the structure of enamel in absence of systemic disorder, result into the this kind of pitting and brownish discoloration affect both the dentition, primary and permanent. Then we will go to the dentinogenesis imperfecta, which is hereditary developmental disorder of the dentin, which in the absence of any systemic disorder, only dental will be affected. There won't be any history of any systemic disorder. There are three types basically. Shield type 1 associated with the osteogenesis imperfecta. Features can be periapical radiolucency, bulbous crown, obliteration of pulp chamber, root fractures, and amber translucent tooth color. And second is the shield type 2, which is hereditary opalescent dentin. Features same as shield type 1. Apart from the osteogenesis imperfecta, there won't be history of osteogenesis imperfecta along with the dentinogenesis imperfecta in type 2. In type 3, which is Brady-Wine type, teeth have shell-like appearance with a bell-shaped crown, occurs exclusively in isolated group in Maryland called Brady-Wine population. Then proceed with the regional odontodysplasia, also known as ghost teeth, localized non-hereditary developmental abnormality of the teeth with extensive adverse formation of enamel, dentin, and pulp. You can see hardly that you can differentiate between enamel, dentin, and pulp on the radiograph. That's why it's known as the ghost teeth. Dentin dysplasia occurs in the form of pits, grooves, and larger areas of missing enamel. It's further divided into two types, radicular dentin dysplasia and type 2 is coronal dentin dysplasia. Now we will proceed with the root formation. Root formation, the development of root begins after enamel and dentin formation has reached to the cemento-enamel junction, as I earlier said. The enamel organ always play an important role in root development by forming Hertwig root sheet, which models the shape of the root. It consists of outer and inner enamel epithelium only. As the first layer of dentin has been laid down, epithelial root sheet loses its structural continuity and its close relation to the surface of roots. And remnants of Hertwig epithelial root sheet persist as an epithelial network of strands or clumps near the external surface of the root, which later known as remnants or rest of molluscs. And this epithelial remnants are found in the periodontal ligament as well of erupted teeth and also known as the rest of molluscs, I told earlier. What will happen if things doesn't go as it has to be? Like if any defect occur at its stage, then it can result into the concussion, dilaceration, or supernumerary root. Concussion, I have explained about that earlier, along with germination and fusion, like two fully formed teeth adhere along the root surface just by the cementum. You can clearly appreciate it in this picture. Dilaceration, abnormal angulation or sharp bend or curve along the root portion of the tooth. It occurs due to the history of trauma during the developmental stage. Supernumerary root, developmental increased number of root on the tooth compared with the classically described in the dental anatomy, which we will be learning in the later part of this video. Due to the disturbance of Hertwig epithelial root sheet forming the root, it will occur due to the disturbance to the Hertwig epithelial root sheet. Now, I think tooth development is done here, and I hope you guys had enough information that you need to know at this level. Now we will proceed with the eruption of the tooth uh, process whereby forming tooth migrate from its intraosseous location within the jaw to its functional location within the oral cavity, given by Moira, Messler, and Score in 1941. What do you mean by this? It means the tooth eruption means the tooth forms within the bony cavity in the alveolar bone. Then it will migrate from, like, it will move to the its osseous location because it is within the bone to its functional location where it will help you to chew and other functions that tooth have to perform in the oral cavity. Phase of the tooth movements are three. First is a pre-eruptive, second is a eruptive, and then third is a post-eruptive phase. In pre-eruptive phase made by deciduous and permanent tooth germ intraosseously. What do you mean by pre-eruptive? Whatever part they have covered intraosseously will come into the pre. This phase occur in the concordance with the jaw growth for compensation. Then eruptive tooth movement. Tooth moves from its position within the bone to its functional position in the occlusion. However, since jaw growth is still occurring, movement in plane other than axial movement suppressed at eruptive phase. What do you mean by eruptive movement? It means that tooth will move from its position to the towards its function position in the occlusion. Okay. Then post-eruptive means these movements occur to maintain its position of post-eruptive movement will occur uh, to maintain its position into the oral cavity after its eruption while the jaw continues to grow. Then we will see mechanism of the tooth movements. There are various controversy regarding that. There are basically four methods they think responsible for the tooth movement. First is a bone remodeling, second is a root growth, third is a vascular pressure, and fourth is a pedial traction. From this four method, pedial traction theory has been most accepted and answered most controversies. So we will be looking to this in depth. Ligament traction theory. First, contractile elements like collagen and fibroblast are responsible. It leads to constriction, then force initiated by fibroblast that transmit to the extracellular compartment by fibronexious and collagen bundles by root formation and ultimately result into the eruption. It is the most acceptable theory until now. If any defect occur in the eruption stage, result into the following defect like natal teeth, neonatal teeth, eruption cyst or hematoma, impaction, ankylosis, or eruption sequestrum. What do you understand by term natal teeth? The teeth that are present at birth, most common natal teeth are lower incisor. It will present at the time of the birth of the baby. Um, okay. And neonatal teeth. It won't be present at the time of the birth, but it emerged through the gingiva during the first 1 month of the life, which is known as the neonatal period. Okay. And then eruption cyst or hematoma. At the time of eruption of the developing tooth, it formed this cyst-like lesion on the gum pad where a tooth supposed to erupt, or else it will be bluish discoloration like hematoma due to trauma that is causing onto the gum result into this, or else it can also result if there is an insufficient force of eruption present, then it can also result into the impaction of the developing tooth. If anything affect the eruption process of the tooth and result into the loss of periodontal ligament in between tooth and alveolar bone, result into the ankylosis of tooth, and ultimately result into the intraoccluded tooth. Eruption sequestrum. At the time of eruption, when tooth is piercing the bone, there will there is going to be necrosis of the bone and result into the sequestrum ultimately, and it is known as the eruption sequestrum. This is the table that you need to be remembered for your exams. This is chronological table of the teeth for both primary and permanent teeth, along with the time the calcification began uh, and at the time which it is completed, when eruption will start for the particular teeth, and when it will root formation will complete it. After the eruption of the teeth in primary dentition, it will take at least 1 to 2 years on average for the root formation to be completed. In permanent dentition, it will take 2 to 3 years for root development to be completed. So that things to be remember for clinical purpose. This is the summary about whatever we have learned right now, how it will origin, component of the tooth germ, cells of tooth germ, and products. Origin, like it will origin from the ectoderm of first arch. Um, then it will develop into the tooth germ ultimately, and it will divide into the enamel organ, dental papilla, and dental follicle. Enamel organ will responsible for the cervical loop, outer enamel epithelium, stellate reticulum, stellate intermedium, inner enamel epithelium. Dental papilla is responsible for the undifferentiated mesenchymal cells, fibroblast, and odontoblast. And dental follicle is responsible for the osteoblast, fibroblast, and cementoblast. The components of the enamel organ ultimately results into the Hertwig's root sheet, reduced enamel epithelium, and ameloblast. Hertwig's enamel root sheet result into the root formation, reduced enamel epithelium result into the primary epithelial attachment, and ameloblast will ultimately result into the enamel formation. And overall, it will decide the crown form. Osteoblast is responsible for the dentinal formation, and undifferentiated mesenchymal cell fibroblasts are responsible for the pulps formation, and cementoblast is responsible for the cementum uh, uh, formation, and fibroblast is responsible for the periodontal ligament, and osteoblast for the alveolar bone formation. Now we will start with the anatomy of the crown. In that, we will compare the basically primary and permanent teeth. Primary teeth crown has been shorter than the permanent teeth. It is constricted cervically, narrow neck than the permanent, and cervical ridge on the buccal aspect are more prominent in the primary tooth as compared to the permanent, which are more flatter. Primary teeth lighter in color, they appear bluish white. Also, that's why they also called as a milk teeth. Okay, and permanent teeth are darker in color and they appear yellowish white or grayish white. Crowns are wider, measured distally in comparison to their crown height for primary teeth, and it's opposite to that for permanent, like cervicoincisal height is greater than measured distal width. Cusp-shaped appearance to the anterior teeth and Scott-shaped appearance to the deciduous molar. And for permanent, it's square-shaped appearance for the anterior and trapezoidal to permanent. You can appreciate the difference between these two teeth, primary and permanent. In primary, there are white crown color, smaller overall size, prominent cervical ridge, and narrow roots. In permanent, yellow crown color, larger overall size with wide root. Now we will proceed with the particular tooth like incisor. In primary, incisor do not exhibit mamelons, but do present in the permanent incisor in newly erupted teeth with the time due to attrition of the incisal age it will disappear, but in the newly erupted teeth you can really appreciate the presence of the mamelons in the permanent incisors. In primary there are noticeable wider mesiodistal, then they are long cervicoincisor, but in permanent there will be more cervicoincisor width than the mesiodistal. In canines, primary canines tends to be more conical in shape. Cusp tip is more pointed and sharp, whereas in permanent canine are less conical, their cusp tips are less pointed. Premolars in primary teeth, they do not have premolars, so there is no comparison between two. The in permanent tooth, two premolars in each quadrant will be present, and its buccal, lingual, mesial, distal, and occlusal view has been put it here in picture. You can see that. Molars, primary and permanent. Primary, they have two molars, but in permanent, we have three molars in each quadrant. Crown of second molar is larger than crown of first molar in case of primary, but first molar is larger in case of permanent than second and third molars. Molars are more bulbous, well-shaped with a marked cervical constriction in case of primary teeth, whereas in permanent molar have less constriction of neck. Buccal and lingual surface of molar, especially that of first molar, converge sharply occlusally, thus forming narrow occlusal table buccolingually dimension. There will be narrow occlusal table in case of primary teeth. Primary molar have narrow occlusal table due to marked conversions, and permanent molar has wider occlusal table due to lace conversions. You can appreciate here. Prominent cervical ridge here in primary teeth and flatter cervical ridge in permanent teeth. Occlusal plane relatively flat in primary teeth. Supplemental grooves are more. Contact area between molars are broader, flatter, and situated gingivally. Whereas in permanent, occlusal plane have more curved and contoured. Supplemental grooves are less. Contact area between molars are more situated occlusally and narrow. Maxillary first molar has three cusps resemble premolar in case of primary, whereas maxillary second molar have four cusps and one accessory cusp resemble the permanent upper first molar. Whereas in permanent teeth, first molar has a four cusp with a one accessory cusp, which is known as the cusp of cerebelli, present in the mesiolingual cusp of the first molar. Whereas in maxillary second molar, there is a four cusp. See, deciduous first molar, and compared to that, permanent maxillary first molar. And here it is a maxillary deciduous second molar, and this is permanent maxillary second molar. You can appreciate the difference here, and you can appreciate the cusp of cerebelli and the permanent maxillary first molar and the mesiolingual cusp. Mandibular first molar has four cusps in primary and in primary teeth. It doesn't resemble to the any permanent tooth, but mandibular second molar has a five cusp and resemble to the permanent lower first molar. In mandibular, permanent first molar has a five cusp, whereas in second molar it is four cusp. You can really appreciate it in the picture as well. In root, primary roots are more delicate, proportionately longer, and more slender in comparison to the crown side. Roots are narrower measured distally for the primary teeth, and furcation of molar roots is placed more cervically. Thus, root trunk is smaller in primary teeth. And same opposite for the permanent, roots are stronger and provide good anchorage in the jawbone because they have to stay for lifetime, whereas primary tooth root have to exfoliate, and that's why they are more delicate. Their permanent tooth root are more shorter, bulkier in comparison to their crown. Roots are broad measured distally, and percussion of the molar is more apically. See, smaller root trunk, and in permanent there is a broad root trunk. They are flat, slender roots because they have to accumulate permanent developing tooth bud in their percussion area. After this, all this information I have given to you, I would like to conclude that both primary and permanent dentition are unique in their anatomy, physiologic function, and the pattern of eruption. Due to uniqueness in their anatomy while doing any procedure, anatomic difference should be taken care of in your mind. It is very important if you want to do any successful treatment. Thank you for the patient listening. It was good to share information and knowledge with you. I hope it will be used to you, useful to you guys, and thank you so much.